الرجيم. بسم الله الرحمن الرحيم.
واتل عليهم نبأ إبراهيم إذ قال لأبيه وقومه ما تعبدون قالوا نعبد أصناما فنظل لها عاكفين قال هل يسمعونكم إذ تدعون أو ينفعونكم أو يضرون قالوا بل وجدنا آباءنا كذلك يفعلون قال أفرأيتم ما كنتم تعبدون أنتم وآباؤكم الأقدمون فإنهم عدو لي إلا رب العالمين الذي خلقني فهو يهدين والذي هو يطعمني ويسقين وإذا مرضت فهو يشفين والذي يميتني ثم يحيين والذي أطمع أن يغفر لي خطيئتي يوم الدين رب هب لي حكما وألحقني بالصالحين واجعل لي لسان صدق في الآخرين واجعلني من ورثة جنة النعيم واغفر لأبي إنه كان من الضالين ولا تخزني يوم يبعثون يوم لا ينفع مال ولا بنون.
Who is the head of Health Center in Lahore? Syed Kamran Ahmed is the head of orthopedic section at Indus Hospital, Karachi, which caters a large area for hand injuries. Dr. Rizwan Haroon is a budding new faculty at Aga Khan University. He is also interested in treating the hand injuries. So I will now request to Professor Chima to share his screen and start his talk about the anatomical and physiological basis of hand injury.
So this webinar is about hand injuries. So this lecture is about some basic principles, not about any particular technique. Problem with hand injury is that they come in all kind of varieties, from simple laceration to extensive crush and avulsion injuries. But there are certain basic principles which one have to keep in mind in every situation. आगे नहीं चल रही भी slide. अच्छा इधर से चलते हैं, ठीक. It is important to understand that what is the real function of the hand. Hand is essentially an organ of information through a sensory input, and then an organ of accomplishment by its grasping and holding. But in addition, its cosmesis is also important. It's an organ of expression. After the face, hand is the most expressive organ of the body. One can use it to express anger, to express command, to express pleasure, and every emotion. When dealing with the hand injuries, one should seek what's the objective. Obviously, healing of the injured tissue is an objective for a surgeon, but that is not enough. We have to restore the function of the hand. Just healing of the wound is not enough of an objective. To do that, it is important to understand the effect of the injury, that how injury affects the hand, biology of healing, and our limited capacity to modulate the scarring. Most of the principle will depend on these three things. Let's start with the healing process. A basic understanding of healing process is necessary to understand the principles of hand injury. We are all familiar with these four stages of wound healing. Whenever there is a laceration or open wound, immediately there is a body reaction to stop the bleeding. That's a survival instinct of biology. After hemostasis, there's a phase of inflammation and then proliferation and remodeling. As soon as there is a open wound, the hemostasis process starts, capillaries constrict, and the platelets, they start aggregating, and they get entangled in the extra cellular matrix, and whole cascade of hemostasis gets started. The platelets also exude the platelet-derived fibroblast growth factor. That stimulates the inflammatory process. What is inflammation? The capillary becomes leaky. Neutrophils come in the wound, and a kind of fight starts between bacteria, foreign material, and our defense mechanism, which is primarily neutrophils. In that process, there is a swelling, there is a local heat, and there is what we will call inflammation. That's the stage. That is a necessary defense of the body against the bacteria. Its extent, how long this phase starts, depends on three things: the quality of the wound, bacteria, foreign material, and the dead tissue. If wound is clean, it is a surgical wound. Extent of the inflammatory phase is from 1 to 3 days, and then the proliferation stage will start. But if there is a contamination, there are a lot of bacteria, there is a lot of dead tissue, your inflammatory phase, this fight between the defense forces and attacking forces gets prolonged. ये मैं आज सोच रहा था, ये ऐसी है जो आजकल कराची के हालात हैं. अगर तो एक शहर का सारा निज़ाम दुरुस्त है और बड़ा क्विकली साफ हो जाता है, तो ये फेज बड़ी मुख्तर होगी. अगर कंटेमिनेशन ही बहुत है और आपके पास आपका निज़ाम ठीक नहीं है, तो ये बिल्कुल जैसे आजकल कराची के हालात हैं, इन्फ्लेमेटरी फेज विल बी प्रोलॉन्ग. और जैसे जैसे इन्फ्लेमेटरी फेज प्रोलॉन्ग होगी, उतनी ग्रैनुलेशन टिश्यू ज़्यादा बने. और आफ्टर दैट देयर इज ए प्रोलिफरेशन फेज, जिसमें फाइब्रोब्लास्ट कम एंड दे स्टार्ट लेइंग कोलेजन और स्कार बनना शुरू हो जाता है. अब ये जो बहुत सारा हमारा जो रिजल्ट है हैंड इंजरी का, वो क्वालिटी ऑफ स्कार पे डिपेंड करता है कि कितनी कोलेजन है, उसकी ओरिएंटेशन क्या है और उसकी क्वांटिटी क्या है. एंड देन ए प्रोलॉन्ग फेज ऑफ रीमॉडल. तो अब इससे जो प्रिंसिपल निकलता है, बेसिक प्रिंसिपल, और ये सबसे बेसिक प्रिंसिपल है हैंड इंजरी का, कि लिमिट द क्वांटिटी ऑफ स्कार बाय शॉर्टनिंग द इन्फ्लेमेटरी फेज. क्योंकि अगर इन्फ्लेमेटरी फेज प्रोलॉन्ग होगी तो आपकी ग्रैनुलेशन टिश्यू ज्यादा बनेगी. वो है तो जरूरी इन्फ्लेमेटरी फेज, लेकिन अगर वो प्रोलॉन्ग हो जाएगी तो ग्रैनुलेशन टिश्यू, एंड ग्रैनुलेशन टिश्यू जो है फाइनली इज रिप्लेस्ड बाय द स्कार. आप इसको कैसे लिमिट कर सकते हैं? बाय डिब्रीडमेंट एंड इरिगेशन. एंड उसमें व्हाट डू वी अकम्प्लिश? रिमूव द फॉरेन बॉडी कंटेमिनेशन, रिड्यूस द बैक्टीरियल कंटेमिनेशन टू प्रिवेंट इन्फेक्शन, and remove all non-viable tissue. ये बुनियादी चीज है, बुनियादी principle है कि limit the quantity of scar by shortening the inflammatory phase. ये समझ आ जाए तो आपके बाकी principle they will just follow. And obviously non-traumatic surgical technique, and there's a role for antibiotics. दूसरा concept जो है other than shortening the inflammatory phase, वो है one wound, one scar. This was the concept by Peacock that in early phases of healing, developing scar is a single unit involving all areas of the wound space. हर चीज इकट्ठी ही heal हो रही है, skin भी है, subcutaneous tissue भी है, tendons भी है, nerves भी है, and the scar will bind everything together. The binding of the immobile and the mobile units together to the scar limits the gliding function of the hand. अब हैंड फंक्शन दो चीजों पर डिपेंड करता है कि जो स्मॉल जॉइंट्स की मोबिलिटी हो और जो ग्लाइडिंग टिश्यू है दैट कैन ग्लाइड अगेंस्ट द नॉन ग्लाइडिंग टिश्यू। अगर ये दोनों चीजें कंप्रोमाइज हो जाए तो हैंड का फंक्शन कंप्रोमाइज हो जाएगा। So remodeling and differential modulation of scar will determine the success or failure of surgical procedure of the hand. अब रीमॉडलिंग कैसे होगी और डिफरेंशियल मैचुरेशन कैसे होती है, डिपेंड्स ऑन द क्वांटिटी ऑफ द स्कार। और वो पहले प्रिंसिपल के साथ रिलेटेड है कि आपने स्कार ही कम बनने दे, जो इन्फ्लेमेटरी फेज है उसको लिमिट करें। And then early movement, stress and movement, that will determine what kind of collagen and direction of the collagen. Age is obviously, being young is always beneficial, उनमें जल्दी mobility आ जाती है। And what's the actually जो determine करती है final result, वो है fate of the surrounding tissue, if they are healthy. अब टेंडन को तो आप स्टिच लगा सकते हैं, अगर सराउंडिंग टिश्यूज हेल्दी नहीं है तो वो मूव नहीं करेगा, ग्लाइड नहीं करेगा। तो ये है सेकंड प्रिंसिपल कि आपने वो मॉड्यूलेशन ऑफ स्कारिंग करनी है ताकि वो जो ग्लाइडिंग टिश्यू है वो ग्लाइड कर सके। अब ये एग्जांपल आपके सामने है, ये एक टेंडन है, ये बोन है और ये टेंडन है, लेकिन वो जब हील हुआ है तो वो उस टेंडन के बोन के साथ देखें कि डेंट स्कार है। अब ये हील तो हो गया टेंडन, लेकिन ये मूव नहीं करेगा। एज अपोज टू दिस इज अ टेंडन and this is a bone, and there is a very flimsy scar which is mobile and which is supple and will allow the movement. So it all depends on adhesions and the scar. The principle क्या है, factor that favor restoration of the gliding mechanism of include minimal local tissue damage, short inflammatory phase, healthy surrounding tissue and early mobility. ये अब अगला प्रिंसिपल है which allows restoration of the gliding mechanism which is essential for the hand function. इसी के साथ दूसरा प्रिंसिपल रिलेटेड है कि conditions are not conducive. Repair of the gliding structure should be deferred. कोई जरूरी नहीं है कि पहले दिन आपने टेंडन जरूर रिपेयर करना है। If these conditions cannot be met, repair of all the gliding structure should be deferred. ये एक ट्राइड है, इन्फ्लेमेशन, immobility and edema. Everything even in its own right is damaging, लेकिन जब ये तीनों चीजें मिल जाएं, तो कहते हैं कि नशा बढ़ता है शराबें जो शराबों में मिले, तो ये बिल्कुल दो अच्छा नहीं बल्कि छह अच्छा हो जाएगी। एंड दैट्स ए किलिंग कॉम्बिनेशन कि पहले इन्फ्लेमेशन है, सेकेंडरी टू इंजरी बैक्टीरिया, ऊपर से आपने इमोबिलाइज कर दिया और एलिवेट भी नहीं किया, एडिमा भी हो गया, तो दैट विल कॉज द प्रोग्रेसिव जॉइंट स्टिफनेस एंड हैंड फंक्शन विल बी ruined. So this triad has to be avoided at all cost. Next principle, वो है wound contraction का। फाइनली wound तो जितना भी बड़ा जख्म हो वो फाइनली हील कर देगा, सर्जन और नो सर्जन, एक नेचुरल मैकेनिज्म। और वो स्कार के और नेचुरल जो मैकेनिज्म है वुंड हीलिंग का वो है स्कार, वो फ्लैप या स्किन ग्राफ्ट नहीं है। और नेवर अंडर एस्टिमेट द पावर ऑफ द स्कार। स्कार विल कीप कंट्रैक्टिंग अंटिल देयर इज सम अपोजिट, जहां कोई इसको स्टॉप नहीं मिल जाता। यू कैन सी हाउ स्ट्रॉन्ग द कंट्रैक्चर फोर्स ऑफ द, कि ये उंगलियां बिल्कुल डार्सन पे लग जाएंगी जब तक वहां जाके रुक नहीं जाती। अगर आपने स्कार को, नेचुरल मैकेनिज्म को, कहते हैं जी वो नेचर को अपना काम करने दें, तो नेचर तो ये करेगी। तो प्रिंसिपल क्या है इसका, एनी ओपन वुंड ऑफ द हैंड मस्ट बी कवर्ड एज क्विकली एज पॉसिबल विद एम्पल टिश्यू टू प्रिवेंट परमानेंट एंड रेजिडुअल डिफॉर्मिटीज सेकेंडरी टू वुंड कंट्रैक्शन। अब इसको आपने जल्दी कवर करना है। वो जो है नहीं, वो ये जो नेगेटिव प्रेशर ड्रेसिंग और ग्रेनुलेशन टिश्यू बनने दे, वो टीबिया के लिए तो ठीक हो सकता है, हैंड के लिए इट इज अ टोटल डिजास्टर। ये है जो फिजियोलॉजी वुंड हीलिंग पे प्रिंसिपल। क्या प्रिंसिपल हुए एक तो आपने इन्फ्लेमेटरी फेज को रिड्यूस करना, उसको शॉर्ट करना है। दूसरा स्कार की मॉड्यूलेशन है। तीसरा ये जो एडिमा और इन्फ्लेमेटरी, ये सारे कम्बिनेशन आपने अवॉइड करने हैं, और जल्दी अर्ली स्किन कवरेज व्हेन एवर द कंडीशन परमिट। अब कुछ प्रिंसिपल हैं which are based on architecture and anatomy. जो फर्स्ट प्रिंसिपल टू अंडरस्टैंड वो है हैंड की बेसिक स्ट्रक्चर, कि एक हैंड का स्टेबल यूनिट है और बाकी मोबाइल यूनिट है। फॉर हैंड टू फंक्शन दिस इज द बेसिक अरेंजमेंट, कि एक सेंटर में स्टेबल यूनिट है विच इज द डिस्टल कार्पल रो और सेकंड थर्ड मेटाकार्पल, मोबाइल यूनिट थंब है, इंडेक्स फिंगर है, ये 3 यूनिट है। ये इस तरह एक सेंटर में स्टेबल यूनिट होगा तो फिर मोबाइल यूनिट काम करेंगे। तो दिस इज और इनके तो रेस्टोरेशन ऑफ दिस बेसिक यूनिट जिसके अगेंस्ट मोबाइल यूनिट काम कर सकें, दैट्स एन अदर बेसिक एनाटॉमिकल प्रिंसिपल। अच्छा, hand is basic architecture of the hand is based on longitudinal and transverse arches. Or maintenance, those arches are necessary for hand to function properly, to look normal, and to have its grasping function. Transverse arches are 2. One is at the carpal tunnel, which is bony arches and maintained by the structure of the bone. But then there is a functional arch at the metacarpal level. At the same time, there is a longitudinal arches. A keystone is at the MP joint. This is the fixed part of the arch, and then the mobile arch for each finger. When these are the oblique arches, each finger make oblique arch with the thumb. When hand is injured, generally those arches gets reversed, like in this ulnar nerve injury. You can see the reversal of the longitudinal arch. The less realized thing is the transverse arch. A hand becomes flat. There are no arches at the MP joint level. So the restoration of or maintenance of the arch is the second anatomical principle. Hand is a grasping unit. And that's what makes human hand unique. That thumb can move and hand can grasp. It's good to compare human hand with chimpanzee hand to have the full realization of the grasping power of human hand. You see, chimpanzee thumb is very small compared to human thumb. It cannot, like human thumb, cannot come over the finger to grasp strongly, and does not have as much mobility due to its very deep metacarpal joint. When you try to analyze what those grasping functions are, grasp can be divided into Persian and power grasp. Persian is on the radial side and power is on the ulnar side. This is the tip pinch, this is the key pinch, this is the pull pinch, this is the chuck grasp. This is a power grip, span grip, using the hand as a pushing tool, and a hook grip. When you analyze all these 8 type of grasp and the holding modes of the hand, you will realize that for 6 of them, thumb is necessary. Only these 2 functions can be done without the thumb. So what is the principle out of this? That thumb has a special place in hand. For most of the function, thumb is necessary, and this is due to its very special movement, which we call apposition, where thumb has to move out of its place forward, then across the thumb, across the palm, and has to rotate to provide the prehensile function. Other architectural principle or anatomical principle is the stability of the wrist. Stability of the wrist is necessary to have a powerful grip, but mobility is also necessary. Even when there is no flexion power of the finger, just by mobility of the wrist, one can open the fingers, and by extension, by some means, it can close the finger. So both its stability of the wrist and mobility is necessary. Function of the MP joint. We are all familiar that MP joint, these collateral ligaments are lengthened in flexion and they are tight, so joint is stable. In extension, they are loose. If you allow it to stay like this, it will contract and then flexion would not be possible. Why this MP joint movement is so necessary? If you analyze the total range of flexion of the finger, about 70% contribution is of the MP joint. Just by MP joint, that covers 70% of the arc. Next 20% would be covered by the PAP joint, and on the last 5% would be covered DAP joint. So keeping these MP joints mobile is one of the essential need of the hand. If you allow it to become a stiff in extension, this will not flex. So that adds another principle. It took me a long time to realize this principle of power and balance. That to function for a protagonist for a distal joint, like for flexor digitorum profundus at the DAP joint, every proximal joint needs to be stabilized by its antagonist and protagonist. Like wrist needs to be stabilized by wrist flexor and extensor. MP joint needs to be stabilized by intrinsic and extensor. And similarly, PAP joint needs to be stabilized by flexion and by extensor. Only then flexor digitorum profundus would be able to effectively flex the DAP joint. So no observed movement in the body is done by a single muscle or tendon. It's the all other joints, intervening joint needs to be stabilized. So it's the power and the balance which is essential for the hand function. Out of this discussion, this principle of safe position emerges, that if we have to, joint is a mobile organ, but if due to any situation we have to immobilize it, it should be wrist in extension. We already seen the importance of the wrist. MP joint needs to be flexed and finger straight and thumb in position of opposition. This is called the safe position. Now there's another concept related to the basic principles. That is called the basic hand. In many situations, normal function of the hand is not achievable. Then one should consider the basic hand. What is the basic hand? That is at least two non-painful digits with adequate cover, sensibility, and durability. Two digits should be able to touch each other with some power. At least one of the digits should be capable of motion to open for grasp. This is the case in example. There are two digits available. One is a thumb, there is another digit. It's better if both have some mobility, but one must have mobility. One is able to do a lot of things. So this would be called a basic hand. Sometimes that should be the goal instead of the normal hand. Next principle related to skin and incision. Skin is very important, and dorsal and volar skin have their own attributes. Two things should be realized in the dorsal skin, that from this position to this position, you need 30% extra skin. So when you are providing the coverage, you should keep that extra demand in mind and provide adequate coverage. But because if you put the skin graft or the flap in this position and have not kept that 30% extra demand in mind, they will the flap or skin graft will not allow your finger to flex. On volar side, this mystery of skin incisions can be understood just by this principle. If you close your fingers, certain part of the skin touch with the other part of the skin, like this part is touching this. When you mark them and open it, they look like diamonds. Principle is that you cannot cross these, you cannot cut your diamonds vertically. You can skirt them obliquely, this way, but not vertically. You cannot go vertically here. You cannot go vertically there. You can go along the sides of those diamonds. That's one of the basic principles. Based on that, you can have many zigzag incision, Brunner incision. There are many forms of that. There's another principle. When you close the finger and see the creases and mark them, that is the neutral mid-lateral line. There's no movement of the skin at this line. You can safely make incision. If you keep these two principles of those diamonds and this mid-lateral line. You can devise your incision according to the need. If you violate that principle, cross those diamonds vertically, you will get these kind of scars. So let's summarize those anatomical and architectural principles. There's a fixed and mobile unit. That is the basic architecture of the hand. Arches needs to be maintained and restored. Prime importance of the thumb must be always kept in mind. Thumb is more than 50% of the responsible for more than 50% of the function of the hand. Safe position, wrist in extension, MP joint in flexion, and thumb in position of opposition. The concept of basic hand is necessary, especially in crush avulsion injuries. We have just discussed the principles of incision placement, skin, its mobility, and sensibility. Those are the principles in addition to those physiological principles based on wound healing. These are the principles which are based on anatomy and the architecture. Now, when you are faced with the open injuries of the hand, these are the things which in order you have to do assessment, which is based on history and physical. Vascularity, obviously, unless there is a vascularity, you cannot move further. Either you have to re-establish it or there should be vascularity present. First, surgical act is debridement. Then you have to make decision in a more severe injury, which part needs to be retained, which part needs to be amputated. And then the skeletal stabilization. You cannot move further unless you have the skin coverage. So you have to assess the availability of skin coverage. Only then think of repairing the tendon and repair in some cases. And only in some cases, you should be closing the wound, only if it allows you to close the wound. Dr. Brigadier Saab would cover some of these, I think, again. But I will just touch and move on. In the field or in emergency, first aid in the hand injury, there are three objectives: stop the hemorrhage, prevent further contamination and damage, and care of the amputated part. Our physician in the field, they need to be educated how to care for the amputated part. History, three things are important. There are some about the patient, about the injury, and the environment in which injury has occurred. Obviously, we are all familiar about the patient: age, handedness, occupation, avocation, goals, objective, personality, all things are important. And factors that can influence the healing: general health, diabetes, some other diseases. About the injury, what's the nature, degree of contamination, and the timing. These are the things which are important. If everything else, we assume that care is going to be good, it's the mechanism of the injury which determines the result. How severe it is, how crushing it is. And environment is also important, whether it's the agriculture field, it's the industrial or home kitchen. And his social environments are conducive or supportive for care of that injured part. In physical examination, these are the things which you have to keep in mind. Severity of the injury, as I just mentioned, that is the key determinant about the results of the injury. Physical status of the whole patient, because that finger or that hand is part of the upper limb and upper limb is part of the patient. First question you have to ask whether it is viable or not and whether you can make it viable. Then there are two questions you have to answer: what structures are injured and what structures are repaired. Because this is all equally important to know what structures are impaired, because that will determine how important it is to repair the injured structures. And factors influence the healing: contamination, crushing, timing since injury, and so on. Your initial assessment, you have to make a general assessment about the nature of the injury, whether it's a clean laceration or whether a crushing injury, is there a vascular emergency, degree of tissue damage and contamination, and tissue system involved. This is a good concept, though old concept, but still I think it's a useful concept. Generally, wound will fall into these two categories. It's a tidy wound or untidy wound. What is a tidy wound? It's a clean laceration, surgical wound, or a clean laceration by the knife, minimum contamination. It can be cleaned, and most of the time it will allow primary repair and primary closure. Untimely wound is a crushing avulsion injury. Degree of contamination is uncertain. Viability of the individual tissue is also uncertain. So these are the wounds which need extensive debridement. Closure is generally not possible, and primary repair would generally not be feasible. Documentation. Let me show the younger people this very simple way of documentation instead of writing paragraphs and after paragraphs. Like this simple diagram. Show you the index finger is normal. In the middle finger, flexor digitorum sublimis is intact, flexor digitorum profundus is gone. One digital nerve is injured, one is intact. In the ring finger, both flexor digitorum sublimis and the flexor digitorum profundus are injured, and both digital nerves are also injured. In the little finger, there is a laceration, but both tendons are intact and both nerves are intact. This gives me much more information than I can verbally convey. This is another principle, that obvious might not be the only injury. Hand injuries are very obvious. They are dramatic. They attract the attention of the doctor and everybody else. But as I said, this hand is part of the upper limb, and upper limb is part of the patient. There could be much more serious injuries more proximally. And see if the patient is stable. Debridement is the first surgical act. And now this is related to your first principle that we have to shorten the inflammatory. It must be understood that natural defense is the best protection against infection, not antibiotics. Anything that impedes delivery of the natural defense mechanism to the site of injury will promote infection. That includes damaged tissue, foreign bodies, hematoma, dead space. So you have to deal with all these four elements. That is your debridement. Remove as many bacteria and contaminant as possible, but at least visible dirt should be removed. When I go back in some wound and still see the visible dirt, that means debridement has been inadequate. Prepare the tissue to resist multiplication of bacteria by removing the damaged and dead tissue. Dead and living cannot stay together, either in the hand, in the body, or in the house. Dead has to go. And antibiotics obviously has secondary role. This must be understood that this is primary and antibiotics are necessary but still secondary. Once you debride, these more dangerous looking wound might not be as dangerous and are generally manageable. Now during the debridement, hand does not have any extra tissues. Skin is very precious. So it may be preferable to retain the questionable tissue and be prepared to remove it later and redebride. Every piece of the skin is important. So skin cannot be discarded as freely as in other parts of the body. But at the same time, that has to go. So this is the decision-making point. After debridement, after assessment, after debridement, you have reached this point where you have to answer these 6 questions. Is the debridement adequate? Because that will determine whether you can repair the structure and close the wound. What needs to be discarded? Now you have reached clean everything. Now you have to make that decision. What needs to be retained? What needs to be amputated? Is there any amputated part that is suitable for replantation? What structure are exposed and what are injured? Is there enough skin to cover the important structure and can the wound be closed? Because this answer to this question is essential before you can repair the tendons and nerves and so on. Is there any closed compartment that can be source of compartment syndrome? So these are the 6 questions which you should ask yourself before moving further. I think I will stop here because otherwise there would be some repetition of the stuff which Colonel Saab is going to cover. So emphasis of my presentation is to touch the basic principles which are related to physiology and our concept of anatomy and architecture. More specific and detail about the structures would be covered by the subsequent lectures. Thank you.
Thank you very much. This was very elaborative. In the interest of, we don't have questions posted in the chat box. So I will request the participant to write their question in the chat box. In the meantime, I will request Brigadier Khalid Masood Saab to kindly share his screen and start his presentation.
I think Professor Tehseen Cheema has covered the basic things and the most important that I myself wanted to elaborate here. And जो मैं कहना चाह रहा था वो सर ने कह दिया है. तो चंद एक चीज़ें हैं कि what should we do when the patient come to you in our emergency department. So I will start from there. So one should keep in mind that, as already told by Professor Tehseen Cheema, that hand is a complex architecture, and most of the time many structures are injured, and it presents most of the time as a complex injury. It is very easy to manage the very simple injuries, but the emphasis here, the way to manage is basically for the complex trauma. When there is more than one structures are damaged, more than one structures are affected. The complex injuries are basically crush and degloving injuries performed by done by the gunshot injuries, high pressure injuries, explosion injuries, thermal and electric burn injuries, and traumatic amputation. How we are going to approach this complex hand trauma? As already mentioned by Professor Tehseen Cheema, that it involves generally multiple structures, and most of the time and many times there is a tissue loss or there can be devascularization. But one must keep in mind while managing such injuries that each patient has unique functional needs, as already Professor Tehseen Cheema told about it, that one must know the profession आपका जो भी है उसका occupation of the patient as well. In history, 3 Qs are very important: when, how, and where. 3 questions are essential in understanding the type and nature of injuries: when, time of injury; how, mechanism of injury; and where, environment in which the injury took place. And generally, these 3 questions explain the nature of injury and extent of the injury. And when the patient comes to us in ER, as already told by Professor Tehseen Cheema, the first step is to rule out the life-threatening injury. And after ruling out the life-threatening injury, it is mandatory to stabilize a patient's vital signs: blood pressure, pulse, and respiration. Then jump on assessing the hand injury. So first do the general management, then go for management or assessment of the hand injury. So hand reconstruction is prioritized in the perspective of overall patient assessment. And in ER, when the patient comes to us, a careful visual assessment combined with the knowledge of anatomy, as already mentioned by Professor Tehseen Cheema, a comprehensive assessment of the structures involved or damaged by the injury can be performed on general anesthesia. So there are 2 types of assessment. One you do in emergency department, and the second you do in operation theater when the patient is under general anesthesia. So in initial assessment, many of time and most of the time, it is not possible that one can assess the every type or everything and extent of the injury. So in emergency department, on visual assessment of the hand, one can assess it by seeing the posture and deformities. And next is the degree of wound contamination, as already mentioned by Professor Tehseen Cheema, and then the surface anatomy. And sometimes one can assess the tissue loss and viability. This can be done by viable healthy tissue appear, which are pink, while traumatized, devitalized tissue or ischemic digits appear pale, white or black. And the extent of the injury, like size of the soft tissue defect and exposure of the underlying structures such as bone and tendons, can tell about the extent of the injury. So right at the time, one can manage the patient with antibiotic and tetanus prophylaxis. And then the patient should be sent to the radiology department for radiographic examination. So standard X-ray views, anteroposterior and lateral, and X-rays should be repeated can be repeated in the operating room when the patient is anesthetized. The next step is the comprehensive wound evaluation under general anesthesia. A clear and organized assessment of the tissue injury or loss makes reconstruction planning easier when you do it under general anesthesia. Here you can assess the type of the tissue loss, soft tissue, bone, nerves, or combination of the all. Then evaluate the structures which are affected by the trauma from superficial to deep. So there is a wound evaluation scheme from superficial to deep, from dorsal to palmar side. First, evaluate the dorsal skin. If the dorsal skin is intact, then it is unlikely that there is a structure which is damaged underlying the skin. If the dorsal skin is damaged, then one should see the extensor tendon. If the extensor tendons are okay, then there is unlikely there is a problem with the bone and joints. If the extensor tendons are damaged, then one must examine the bone and joints. And if the bone or joints are damaged, then one should assess and evaluate the flexor tendons. And if the flexor tendons are injured, then one must evaluate the vessels, nerves, and then the palmar skin. From the palmar side, it can be the vice versa. Prioritizing the salvage during surgery. It is also called the intraoperative triage. And one must evaluate the significant and soft tissue loss or substantial bone loss, joint injury involving the ligaments or the cartilage, and tendon injury or loss, vascular injury, and nerve injuries or loss. As already mentioned, the documentation is mandatory in all hand injuries. It shows the severity of the injuries, and it is essential to carefully document the extent of the injury. Now, one can take the clear photographs of the entire wound as well, because the medical photographs have many benefits in the setting of complex trauma. Now come to the management. Two things are very important. One should know that whether it is an emergency surgery or when should it be performed. ये surgery होनी कब चाहिए? So it should be in your mind, should be clear about it, that the complex hand injury should receive immediate surgical treatment, because delaying treatment may result in critical ischemia of damaged tissue and skeletal muscles, and there can be increased risk of infection as well. So goals of the reconstructions are, as already elaborated by Professor Tehseen Cheema. One is the basic prehensile hand, like one should have a stable thumb with two or more fingers that can perform pulp to pulp contact with the thumb. And the digits and the thumb should be sensate and pain-free. These are the basic requirements for construction of the hand injuries. So there are certain salient steps of the management. First step already mentioned, which is done immediately. That is the debridement. In debridement, excision of the all necrotic and non-viable tissue should be performed. And second step is the skeletal stabilization. After that, this step should be performed. After that, vascularization should be performed. The next step is the tendon and nerve injuries, nerve repair. If the nature of the injury allows you, it can be done primarily if the wound is clean and nature is allowing you and the condition is in favor of the patient and the surgeon as. Otherwise, this can be pended and should be followed by the soft tissue covering. Then the second stage is the early second stage management that is done within 72 hours. And it is performed when the wound condition is not favorable. Second stage reconstruction is performed within 72 hours. Here, the definitive soft tissue of the defect should be performed, and the coverage should be done by the pedicle flap, or free tissue transfer can be done in this stage. Skeletal reconstruction or revision of the fixation can be done, and nerve reconstruction and tendon reconstruction is performed. Here in this stage, surgical preparation or for sources of the tissue, some other preparation should be kept in your mind, and these should be done right at the time in operation theater. The lower limb should be prepared if one anticipates the need for vein graft or sural nerve graft. The iliac crest should be prepared if the surgeon anticipates the bone graft. Then the preparation of the groin or abdomen if one anticipates a groin flap or abdominal flap. Then most important are the spare parts. These can be obtained from the non-salvageable tissues like nerves, tendons, bone, and skin grafts. In nerve, tendon, and soft tissue reconstruction, the definitive management is performed within 72 hours. The commonly available options are skin grafts are the soft tissue coverage are the skin grafts, groin flap, abdominal flap, lateral arm free flap, and flow through flaps when soft tissue reconstruction is combined with other reconstruction. Definitive soft tissue coverage can be postponed to early second stage when there is a significant risk of infection. And after debridement, the wound should be very clear. There should not be any evidence of the infection, and it can be covered with any sort of the flap. Then prioritizing salvage during surgery. Number one, all attempts must be made to preserve the thumb. Number two, digits are raised that can be reconstructed with a good functional outcome should be distinguished from digits that should be sacrificed for use as spare parts. Then number three principle, the least injured digits with maximum functional potential should be reconstructed as priority. Like example, this patient have crushed sort of injury involving thumb, index finger, middle finger, and after debridement, the maximum effort should be made to repair the thumb or salvage the thumb. And one can sacrifice the index finger as well here. And like this example as well, there is a crush injury involving the thumb again and index finger. So one can see the salvageability. Here the thumb, the index finger is not salvageable, so it can be amputated, and the skin of this area can be covered to, can be managed to cover the defect. So this is post-operative, early recovery, and maximum functional output. Then there is a concept of the spare part concept. The concept of spare part surgery should always be kept in mind. Non-salvageable rays or digits can be a source of skin graft, nerve grafts, bone graft, and articular grafts. And structures that are sacrificed should not be discarded until the end of surgical procedures. Like this example, here the non-salvageable part are excised and the skin is used to cover the defect. Like this example, a patient 39-year male with firearm injury that has injured the middle and index finger and managed initially somewhere with amputation of the middle finger. And there is a gangrenous and necrotic wound over the index finger. And there was a bone defect in the proximal phalanx as well. So debridement was performed with skeletal stabilization, and the defect was planned to cover with the rotation flap from the middle finger that was already amputated. So debridement and use of the tissue bank like spare part from the middle finger area, the skin, as well as the bone from the middle metacarpal and the nerve. These were used to cover the defect and to manage the nerve injury and to manage the bone defect as well. And bone defect was managed with taking from the same area, and it was fixed with 1.5 mm screws, and extensor tendon graft was also taken, and the extensor tendon was managed, and soft tissue and the nerve was also taken, and soft tissue coverage was done with the rotation flap. And this was the position after 1 week, and after 2 weeks, and after 6 weeks, and it was quite functional hand after 8 weeks. Next important is the rehabilitation. Rehabilitation should commence as soon as feasible after soft tissue coverage. It remains an integral part of management, and it is essential for functional recovery as well. The therapy is aimed to maintain joint mobility and prevent adherence. Here there is a role of the skeletal fixation. As the skeletal fixation is strong and tendon repair is good in previous stages, and that allows early mobilization as early as possible. Then the next stage is the late reconstruction. Late reconstruction is within 3 to 6 months after the initial injury. At this stage, all the tissue have healed and hand function has reached its maximum potential. And surgery should be aimed to enhance existing function and correct the deformities or improve the aesthetic of the hand. In late stage reconstruction, the following procedures are generally performed. These are the tendon graft, tendon transfer or tenolysis, nerve graft or neurolysis, bone graft, bone lengthening or corrective osteotomy are performed on this at this stage. One can do the joint fusion, contracture release, toe transfer or debulking of the flap is performed on late reconstructive phases. Like the toe transfer, when there is situation of, or one can already have lost the thumb, then the toe transfer can be performed in late stages. Then there is a concept of the auto tissue preservation. It is done when the recipient side not favorable, when there is an infection at the recipient side, and when there is a necrosis or the bed is poor, and there is a vascular compromise. Like this case, there is a crash injury and loss of the thumb, but the recipient and the thumb area is not favorable. So it needs secondary reconstruction here. And this is the other way, and these are the X-ray. See, only the metacarpal, first metacarpal is here, rest of the thumb is not, has already amputated. So in such case, there is a part that thumb can be amputated at an area where the recipient side is favorable for a time period, and the actual recipient side is managed, as already mentioned, to become a healthy area to receive it in a next stage. So when the original recipient area has become favorable, then the thumb can be again replanted there, and defect can be covered with the help of the flap. So one can get the excellent functioning hand after a certain period of time. So summary of the complex hand trauma management is that first stage, that is the immediate stage, is the complex debridement, complete debridement, followed by skeletal stabilization, followed by revascularization. Then immediate procedure for soft tissue coverage is essential if the vessel and nerves are exposed. Then the tendon and nerve reconstruction should be performed in the first stage whenever feasible and there is adequate soft tissue cover. Next is the early second stage, that is within 72 hours or 3 days. That is again soft tissue coverage, nerve reconstruction and tendon reconstruction. And then the late stage, that is basically the rehabilitation, and followed by the late reconstructive stage, that to enhance the existing function, aesthetic and deformity correction. Here the bone graft, corrective osteotomy, contracture release, joint reconstruction and nerve graft, tendon transfer, penolysis, toe transfer, flap debulking is performed. Thank you very much. If there is any question.
Thank you, Khalid Saab. In the interest of time, we will be entertaining question and answer at the end of this webinar. Kindly unshare your screen. Now I will request Professor Kamran to share his screen, and he will speak about the extra-articular fractures of the hand, metacarpal and phalanges.
Assalamu alaikum.
Walaikum salam, Kamran.
Bismillahir Rahmanir Rahim. Rabbi shrah li sadri wa yassir li amri wahlul 'uqdatam min lisani yafqahu qawli. I'm extremely grateful to Haroon Saab, Pakistan Orthopedic Association and Pakistan Society for Surgery of Hand for giving me this opportunity. Speaking after Professor Cheema and Brigadier Saab is a difficult task. Professor Cheema has covered most of the things. As rightly said by my great teacher, Professor Cheema, and you all know, a hand is a tool for function, and not only a tool for function, but it is also a tool to express emotions. Now, the emotions that have been elaborated by Professor Cheema, if you see this is anger, this is authority, and this may be accomplishment. But how can you achieve these emotions if you do not have mobility, if you do not have acceptable structural integrity, and if you do not have coordination? And this is the basis of any hand surgery, and especially fracture surgery. So if we go into the details, minute details of angulation and art and rest of the stuff, that may make sense. But the first and foremost thing that may make sense is hand function. So we have to assess hand function in a nutshell. All of us are aware of this diagram. What do we see here? Obviously, we see malrotation. If the fingers are not pointing correctly towards the scaphoid tubercle while you try to make a fist, obviously there will be some hindrance. And that may at times lead to significant loss of hand function. Again, it has to be individualized, but this is not an acceptable position. So let's go on to some basics for phalangeal fractures. Let's take this slide. A 34 years old male sustained closed finger injury shown in figure. This is 1 week ago. So what is responsible for this deformity? Now this is where we have to understand the biomechanics of injury. So what is the biomechanics of deformity in phalangeal fractures and metacarpal fractures? If you see the phalangeal fractures, you can see these tendons going on the dorsal side as well on the volar side. So introitiae come from the volar side, whereas the extensors come from the dorsal side. And most of the phalangeal fractures will have an apex volar angulation because of the effect of these two tendons. The introitiae tend to extend the distal fragment, whereas the extensor tendons tend to flex the proximal fragment. However, if we go to the middle phalanx, there may be a subtle difference. If you have an injury which is distal to the FDS insertion, then you will still have a apex volar angulation. But if you have an injury which is proximal to the FDS insertion, you may have an apex dorsal angulation. Coming on to the metacarpals, how will the deformity occur? Again, with the effect of the intrinsic as well as the extrinsic flexors, you can see that there is a apex dorsal angulation because the distal fragment tends to flex. And the more distal the deformity, the more severe that angulation can be. And that may lead to loss of the knuckle and prominence of the displaced proximal fragment as a result of shortening. So these subtle things have to be understood before embarking on the treatment of hand fractures. The same thing that we are seeing here, how flexion of the joint leads to a tight extensor mechanism, and that may be a stabilizing factor at times while we are doing immobilization in splints. So what is unacceptable position in finger fractures? Anything, and what I'm talking about is phalangeal fractures, not metacarpal fractures. So anything more than 10 degrees of angulation, greater than 2 millimeters of shortening. Rotational deformity, as I have shown you that diagram, rotational deformity is not acceptable. And we have to identify unstable fracture patterns and irreducible fractures. Now, what is an unstable fracture pattern? We know most of the short oblique and transverse fractures may be stable. But as we have long oblique fractures, some spiral fractures, comminuted fractures, so they become unstable. And similarly, if you have multiple fractures, that will constitute an unstable fracture pattern. Now, sorry, go back here. I see a lot of screens, Dr. Harun sir. How can I take these screens off?
क्या हुआ? Sorry, Kamran.
मुझे बहुत सारी screens नजर आ रही हैं, तो अपनी presentation नहीं नजर आ रही, screen नजर आ रही है.
अच्छा, वो anyway, आपकी सेटिंग में जाके ना वो स्पीकर व्यू पे कर देंगे ना, फिर ठीक हो जाएगा. अच्छा, ऐसा होता है कुछ? हाँ, टॉप राइट कॉर्नर, नहीं टॉप राइट कॉर्नर पे आ रहा है स्पीकर व्यू. क्या करूं? स्पीकर व्यू वहाँ पे लिखा हुआ आ रहा होगा स्पीकर व्यू.
स्पीकर व्यू लिखा हुआ आ नहीं रहा है. अच्छा चल, अच्छा है, इसलिए मुझे नजर ही नहीं.
ओके, अच्छा, we can see it very clear and we can hear you also very clearly.
चले यहाँ से ही करते. अच्छा जी, so what will we do with this fracture? क्या करना चाहिए इसके? Now, अगर आप यहाँ पे देखें, this thing has been fixed with percutaneously with a K-wire. So this percutaneous technique has been utilized going in from the metacarpal head, and you can see two wires. In my personal practice, I do not do this very often because it leads to, if you have passing parallel K-wires, you can impinge on the extensor tendon. So I tend to go from the sides of the tendon rather than going. What is the name of this technique? It's called Eaton-Belsky pinning technique, and this has been quite popular. But if you see recently, then most of the people will try to skirt the extensor tendon rather than going through the tendon. And even a single wire at times can stabilize a fracture which is unstable in the proximal phalanx like this. And the advantage of not going through the metacarpal is you can start early range of motion. You can still have one or two wires going into the proximal phalanx, and early motion obviously will lead to early restoration of hand function. So there are multiple articles. This was an article in which 12 unstable extraarticular fractures were treated with K-wires, and early joint motion was started, and excellent results were observed in those patients. Similarly, 50 patients were treated with closed reduction and percutaneous pinning using one of the two techniques, going through the metacarpal head or going or not going through the staying extraarticular. And people did not find a lot of difference in long term. But yes, there have been cases, there are papers where people have found it statistically significant not to go through the metacarpal head because it may cause some residual stiffness in the joint. So again, another study depicting the same. So periarticular may be preferred as compared to going through the joint. So what are the other methods of treatment? So you can use mini fragment screws, and you can do mini fragment fixation with plate and leg screws alone, K-wires, and buddy taping. Now in routine practice, most of us are aware, and this is my practice as well, that we tend to treat most of these stable fractures using buddy straps. And if required, you can actually supplement it with a splint or a cast in functional position of the hand. But if the fracture is unstable and it cannot be managed in a cast, then we have to change. And then as we change, our general practice tends to go with K-wires. This is our general practice. But you see the list is reversed. And why the list is reversed? Because if you fix something in a very good manner, you can start range of motion. With K-wires, again, the start of range of motion may be delayed. But again, K-wire is a very good option, but then you have to remove the K-wires very early, like in 3 to 4 weeks maximum. 3 weeks is usually the cutoff point. And then start range of motion. If you use mini fragment fixation with plates or screws, then obviously you can start motion relatively earlier. And even if you do buddy taping, the idea is that the fracture is stable. And you can allow some motion with the other finger as a buddy. And if it is not possible, then you have to think of another option of treatment. Now take this one, this case for example. Now again, when you see this fracture pattern, what things come in your mind? Now, is the position acceptable? Is there rotation? Is there angulation? Is there shortening? So if you see this carefully, yes, there may be some element of rotation. And if you see the acceptable criteria for shortening for phalanges, it may be just on the verge. So yes, you have to see the patient clinically. And if you see that the fingers are overriding, and I'm going to show you a picture of what else we can see, then we have to consider this for some other treatment. So what should we do? Is closed reduction required or leave as such? I would suggest, yes, do a closed reduction, do a buddy tape at least, or apply a splint. And would you recommend surgery for this patient? So surgery should be recommended only if we cannot treat this fracture using a buddy tape and a splint. So this is what was done in this patient. And you can see that the alignment became more acceptable. There is no rotation. So yes, we can accept this position, but do not go with this splint anything more than 3 weeks. 3 weeks is the maximum cutoff, and you should be able to start range of motion. If you cannot do that, if you think it is unstable at week 1, if it tends to displace, you should go on and do some sort of fixation. Now, take this one for example. This is a 1 month old, around 3 weeks, 1 month old injury. What are we going to do with that? You can see rotation, you can see displacement, you can see angulation, and nothing is acceptable. So at 1 month, obviously it is not for any sort of conservative treatment, and you see what is happening. So even with phalangeal fractures, it is not only for metacarpal fractures, you can see overwriting of the digits, and again, this is not an acceptable scenario. So this is what was done, open reduction, then use a K-wire as a tool for reduction. You can even use it as a joysticking tool. Then a 1.5 mm plate was used to fix this fracture. This is a locking implant. And so this is what was achieved after surgery. And you can see very stable fixation. And by this means, you can allow early range of motion. So this way, this one, we have gone through the extensor slip and it can be repaired very stably. So allow range of motion. If you do this fixation and you put the hand in a splint for many weeks, then the entire goal of surgery is deferred. So this patient was allowed range of motion within few days of surgery as soon as the edema settled and pain settled. And the patient is doing well with this reconstruction. Now take this one for example. If you have open fractures and if you have comminuted, if you have contaminated wounds and open fractures, what to do? Now see, this is a multi-fragmentary fracture. Obviously this is unstable. So what are we going to do? Can we just use a K-wire? So I would not suggest that. You can use a K-wire as a stabilization tool, as an interim tool during surgery. But for these injuries, the K-wire is not an ideal implant. It can be used in difficult circumstances. We can use two crossing K-wires, but it is not an ideal implant. So it can be as an interim tool in surgery, and we should achieve a stable fixation, either using something like a mini fragment plate or a T-plate, whatever works. So because we want to achieve this endpoint, this is the endpoint. So this is the endpoint where you can show those emotions of authority, accomplishment, and anger. And this is very important for hand function. Another fracture pattern. Now we know this is the thumb proximal phalanx, and you can see that this is a relatively unstable fracture pattern. So if we see a fracture pattern like this, we have to consider fixation rather than just going for a buddy tape. So now this is what we have to see whenever we see a fracture. What is a fracture pattern? Is it stable? Is there malrotation? Does it need surgery? And what surgery? So if the fracture pattern is long oblique and at times spiral or comminuted, this may require surgery. Is it stable? The one we saw is not stable, then we require surgery. If there is malrotation, most likely, then we should check clinically, require surgery. Yes, anything which is unstable preferably should be operated. And what surgery? Can leg screws be done? Now, this is a very important concept. Can leg screws alone be used for these patients? Now, take this diagram. Again, you can see in the middle of the diagram, there is a malrotation. This is obviously unacceptable, but see the right hand picture. You can just see tilting of the nail. Even this is subtle malrotation. So we have to see these subtle malrotation, and at times these need to be corrected, because as the hand goes into full flexion, this subtle malrotation is going to become a lot more. Now, this is the principle. When leg screw should alone be used in longer segments. If you have a long segment, ideally we should be able to achieve 3 leg screws. And you can divide this segment into thirds, and each leg screw should be in the middle of the third. If you have a relatively shorter segment, you should be able to achieve at least 2 leg screws. And then again, you have to divide it into 2 halves, and the leg screws should be in the 2 halves. So if your oblique fracture or your spiral fracture is shorter, very short, then and can hold only 1 leg screw, you should not be doing only leg screw. If you are doing leg screws, at least 2 leg screws. This should not happen. They should not converge like this. So why have they converged like this? So it will happen only when your leg screws are not perpendicular to the fracture line. So this should not happen. This is wrong. This will make it an unstable construct. Similarly, if you are placing a leg screw, it should not be very close to the fracture. Take the screw diameter as the head diameter as a landmark. And from both sides, you should have at least 1 screw diameter. Otherwise, you will tend to have another fracture, and there may be a secondary problem as a result of surgery, comminution. So we tend to have proximal phalanx flexion deformity in many cases. So if you have a problem, you should think of using a dynamic splint, and the dynamic splint will tend to correct the deformity, and at the same time, it will allow range of motion as well. At times in fracture patterns where you would like to splint, do splint the metacarpophalangeal joint in functional position in 70 to 90 degrees, and the finger, the proximal and distal interphalangeal joints in relative extension to avoid this problem, and obviously leave the wrist as such and allow early range of motion at 3 weeks. What to do with metacarpal fracture? Now the principles actually remain the same. The biomechanics we have discussed. Again, metacarpals are very common hand injuries. Men usually have them 10 to 29 years of age is the peak. Metacarpal neck is most common, and we know that the fifth metacarpal is more common as compared to the other metacarpal injuries. And multiple metacarpal injuries are seen in cases of polytrauma. So again, what is acceptable? It has to be a stable pattern. There should be no rotational deformity, and it has to be acceptable angulation and shortening. Now we have to keep these things in mind whenever we are dealing with a metacarpal fracture. Now, so what is acceptable? If you see the acceptable shaft angulation, shortening, and acceptable neck angulation, you can see the angulation at the index and long finger. They are lesser as compared to the ring and little fingers. And Dr. Chima was telling you the concept of fixed and mobile units. Because as we go towards the ulnar side, we have more mobile units, so more shaft angulation may be acceptable because of excessive mobility. Similarly, if you see the acceptable neck angulation, they are a bit higher as we go from index and long finger to the ring and little finger. As far as the shortening is concerned, 2 to 5 millimeters can be accepted. Now, this will vary from person to person. If you have a very active person who has very active use of hand, you will tend to restore anatomy. But if you have a person with a sedentary profession, there is no rotational malalignment, you can err towards the 5 millimeters rather than the 2 millimeters. So what are the operative indications in extra-articular fractures? And I'm not touching the articular and periarticular injuries. So open fractures, unstable fractures, unacceptable alignment, multiple fractures, and polytrauma. So these are the general indications where you would like to fix and where you would like to operate and allow early range of motion. And how do you do that? Again, you can immobilize in functional position. Now, as far as the metacarpals are concerned, as compared to phalanges, I would suggest that a splint is still a very good option. If you have a stable fracture, you can apply splint for 3 weeks. The maximum can be 4, but I never do beyond 3 weeks, because if something is stable, you should be able to allow some MP joint range of motion at week 3. If it is not possible, you should fix. K-wire is a very good option again, especially for stable fractures of the midshaft. You can use 2 oblique wires and they work wonders, especially in metacarpals. But yes, with the advent of mini fragment plates, especially these locking implants, the 1.5, the 2 mm plates, you can use these plates and they work very well. And you can allow very early range of motion. Beware of the thickness of the implant. If the implant that you are using is very thick, it is actually not helping you. A K-wire may be better than a very prominent plate. So you can use external fixators in comminuted fractures, in open fractures. And again, the leg screws can be used alone when you follow the principle that we have discussed in the last few slides. So again, the leg screws can be used in long oblique fractures where you can use at least 2 or preferably 3 leg screws, and similarly in stable spiral fractures without comminution. Now, this is the 5th metacarpal fracture, and you know how this happens, commonly called boxer's fracture. Now, what to do with that? Again, most of these fractures, because again, this is the mobile unit of the hand, and a lot of angulation up to 50-60 degrees can be accepted. So you can accept a lot of angulation, but we should try to reduce this in all cases. And how you reduce that, we know there is a Chaz maneuver. You flex the MP joint to 70 to 90 degrees, and you use the little finger to push this distal fragment dorsally, and you reduce that, and you apply ulnar gutter splint again. Do not immobilize the entire hand, just immobilize the ulnar aspect of the hand. And do not immobilize for anything more than 2 to 3 weeks. Try to achieve early range of motion. Don't have a stiff hand. If you cannot do that, you can do close reduction, and you can use antegrade versus retrograde pinning. Both can be used. There are many proponents of antegrade pinning. You can stop them short of the joint, or you can use the collateral recess and do a retrograde pinning. But if you cannot achieve a close reduction and you cannot achieve a percutaneous spring using a closed reduction, then you should use a implant like a mini fragment plate. But beware, this is a very small fragment and it hardly accommodates few screws. So when you are thinking of fixing this, keep this factor in mind and do look for comminution, because this should not happen that at the time of surgery you understand that your decision was not right and you have added an incision, a wound to the already existing injury. So this is another example of a metacarpal fracture. This is a week old or 10 days old injury, and you can see excessive deformity. We cannot accept this deformity. So when you see something like this, even if it is a single metacarpal fracture, you should be fixing this. So this was fixed again with a 1.5 mm mini fragment implant, and this is a stable fixation. And do look for the cascade at the end of surgery. There should not be significant rotation, and you should be able to make a fist without having a significant rotation. So what should we do in phalangeal and metacarpal extraarticular fracture? The first and foremost thing is anatomy and the principles of hand surgery. We should understand the biomechanics, and we should adhere to the principles of hand surgery, very elaborately explained by the last two speakers. So fix when needed. Do not run away from fixation, but do not do excessive fixation when not required. We should be able to start early range of motion no matter what we do. Even if we are doing a splint, it should be a splint. We should allow early range of motion. In rehabilitation, do consider dynamic splints to achieve something which has been lost, like PIP joint flexion deformity or lag, and do not accept rotation. Thank you so much.
Thank you, Kamran, for a very elaborative talk on extraarticular fractures of phalanges and metacarpal. And I will request Dr. Rizwan Saab to kindly share his screen and start his presentation.
I would like to thank Dr. Harun for giving me the opportunity to present at this forum in front of the esteemed professor, Dr. Tehseen Cheema, Dr. Pervez, and Dr. Kamran. So I will be talking about the intra-articular fractures and the extra-articular fractures of the hand. So we have been discussing the entire morning about what are the importance of hand fractures, what are the problems of hand trauma. So the problems are loss of ligamentous restraints, and secondly, there is also loss of tendon attachment. There is also loss of structural stability in the form of deformity and subluxation, and at the end there is also loss of cartilage. So what are the operative indications? So the Professor Kamran just elaborated on this concept. So if this is anatomically unstable, you have to operate, and if it is functionally unstable, you have to operate. So whenever we are going for a surgery, there are certain aims. In this part of injury, so we have to have a very accurate reduction and stable fixation, and most importantly, early motion. If you don't make your patient move your hand, so he will end up in stiffness. So no matter how good the X-ray is, but the results will be not good. Whenever you are planning for fixation, there are two things. You need to know the location of the fracture fragments, which determines the surgical approach, and also the size. If you have got comminution, you don't put lag screws. So this is very important, and it determines the fixation strategy. These are the general concepts. So if the size of the fragment is about 5 mm or more, you can try 1.5 screws, lag screws. And if it is less than 5 mm, so you can do a key wire fixation or a hook plate. And whenever there is combination, you can mix and match. It can be an a la carte. You can put in a K-wire or put an external fixator to support it. So let us begin. The most important part of the hands. This is the thumb. So first I will be talking about briefly about the Bennett fracture. It was described by Bennett, an Irish guy, in 1882, and it is an intra-articular fracture to the base of the first metacarpal. The shaft dorsal dislocated laterally due to the pull of the abductor pollicis longus, but the medial fragment remains in place due to the volar oblique ligament. Most of the time the reduction is easy, but very difficult to hold and maintain. And most of the time they end up in close spinning. Sometimes, in some cases, you need to do an open fixation as well. How does it happen? It is basically an axial force directed against a partially flexed metacarpal and usually occurs whenever you are punching a hard object like a skull or the tibia of the opponent or wall. And it can also occur with as a result of fall onto the thumb. This is the deforming force. The abductor pollicis longus pulls the fragment proximally, but the palmar ligament, oblique ligament holds the medial side, medial fragment in place. That's why whenever you are fixing, you don't consider fixing the medial fragment, but you have to negate the pull of the abductor pollicis longus. So this is a very, most of us have usually done this thing. This is a Wagner technique. You just pull an axial traction, press against the base of the metacarpal and just pronate and you will be able, there are various combination of wiring, whether you pass the wire through the hamate or you pass the wire to the second metacarpal. So whatever you are good at, you should do that thing. Sometimes you need open reduction and internal fixation, and the plane is usually between the flexor pollicis brevis superior head and the abductor pollicis brevis. But you have to be sure of to keep the sensory branch of radial nerve intact. Otherwise, there will be lots and lots of problems. Usually, the postoperative care is you never put any hand with fracture in cast for more than 4 weeks. And if you have got a very stable fixation, so you should do early range of motion. There are various complications with every surgical procedure. In this case, malunion, CMCJ arthritis is very common. The reduction should not be attempted after 6 weeks because it's united. And sometimes you need to do corrective osteotomy, and arthritis is the endpoint if there is problem. Another important fracture is reverse Bennett fracture. The same thing happens on the little finger, the fifth metacarpal, and it is also very unstable. Just it behaves like in the Bennett it was abductor pollicis. Here there is the extensor carpi ulnaris, and you have to stabilize. You just have to negate the pull of the extensor carpi ulnaris, which is the deforming force. Here you can see the hypothenar pulls the metacarpal towards the radial side and the extensor carpi pulls it proximally. Next very common fracture is the Rolando fracture. It is a comminuted metacarpal base fracture, usually present as Y and T pattern. It usually differs from Bennett in the fact that it has no diaphyseal displacement. And since it is a comminuted intraarticular fracture, so you need to have an accurate reduction. So various techniques have been used. You either can use K-wire, you can use T-plates. These plates are easily available in Pakistan, locking plates. And you can also use tension band wiring. I have no experience with tension. Dr. Harun uses lots and lots of external fixators, sort of small mini fixators for these injuries. Very good results. Here you can see close reduction, as the deformity is usually flexion, so reduction can be performed with axial traction on the thumb, simultaneous pressure on the dorsal aspect of the basal diaphyseal near the fracture site. So the maintaining reduction is the key. So whenever you are applying the cast, it is important to exert pressure over the dorsal aspect of the first metacarpal diaphyseal base and from the palmar aspect of the first metacarpal head. Otherwise, if you didn't do this, so opposite deformity, like extension deformity, will appear. So whenever on the left-hand side of your screen there is a cross, don't apply a splint for Rolando in this position. So this is basically the right. So avoid pressing from the palmar aspect over the base of the proximal pharynx. This results in re-displacement of the flexion and hyperextension of the MCP. So sometimes you need open reduction and internal fixation. What choice? So there are two commonly used approach. When if the fracture is in the T and the Y plane, so a straight dorsal approach is usually suffice, and we can apply a T condylar plate or mini fragments plates. But if the Y or T shaped fracture pattern is in the sagittal plane, so you do a radio-palmar approach. Open reduction can be, this plate is available in Pakistan, so I have applied in a few cases, good outcomes. So a rare injury now, so we will be quickly going because this is a very big topic and I've got only 20 minutes to cover it. So thumb CMC joint dislocation, if they are rare injury and mostly dorsal. Dorsal-radial and volar oblique ligaments are most important in preventing dislocation. They should be reduced and immobilized early for about 4 to 6 weeks. If unstable, dorsal-radial ligament repair and immobilization for 4 weeks. Recurrent dislocation usually warranty ligament repair and immobilization. So this is an example of the dislocation. You just press it and do a slight hyperextension maneuver and they will usually get in place. You have to protect your reduction with the help of a thumb spica or modified hand orthosis. So, thumb metacarpophalangeal dislocation. Most common is dorsal dislocation, and the mechanism is usually hyperextension type of an injury. Most common among the all metacarpophalangeal dislocation, it is simple and reducible. Sometimes it doesn't reduce. So you have to be very careful. Don't attempt again and again and again in the emergency room. You are not doing justice to the patient. There is certain interposition of sesamoids or volar plate or some flexor tendon, and they warranty open reduction. So usually mobilization is in 20 degree of flexion for 4 weeks. This is an example of this, and I've already discussed. Next, it is much less common than the IP dislocation and commonly seen in index finger. And the dislocation results in Kaplan lesion when the volar dislocation in the tendons, the head of the metacarpal will get buttonhole. The fibrocartilaginous plate avulses from the volar aspect of the second metacarpal neck, which is the weakest point of attachment. And the flexor tendons and the peritendinous bands are displaced ulnarly, and lumbricals are displaced radially to the metacarpal head. So they are just holding the metacarpal head from reducing. So this is just a basic diagram showing the lumbrical muscles, the superficial transverse ligament, and how it is getting buttonhole. So this mostly warranty open reduction, get rid of this buttonhole. This on the above screen, you can see that this is a reducible, so there is no interposition of the volar plate and they can come back. But in this case, if you try to reduce this closely, this is irreducible. You just take this thing out and the phalanx usually relocates itself. So incomplete dislocation are usually easily reduced. Complete dislocations, 50% success is by close reduction, and some 50% requires volar or dorsal approach and division of the volar plate. So you have to protect it from hyperextension for 3 weeks at least. Boxer's fractures, Dr. Kamran has briefly elaborated. I will just going into a bit of detail. So we have seen this a common fracture. So metacarpal head is free from any proximal stabilizing influence. So metacarpal head tilts volarly, causing joint line to line hyperextension and collateral ligaments become slack. But since Dr. Chima has told us that the more the ulnar the metacarpal, the more the mobile units they are. That if the joint is allowed to remain in hyperextension, collateral ligaments will shorten and leading to limited MCP flexion. And sometimes the head of the metacarpal is also involved in boxer's fractures. This is the angulation which was discussed by Dr. Kamran as well. You can see these are the lateral radiographs. Here it shows displacement about 40 degree angulation. So usually, non-operating treatment should be warranted if you are able to hold a reduction in place. Clawing results from palmar displacement of the head, which we have seen in the X-rays. It results in an imbalance of the extrinsic tendons, and patient may have cosmetic deformity, but since this is a mobile unit, it has got good function. So collateral ligaments must be placed in a tightened position. The jazz maneuver, which Dr. Aman Hamad has elaborated very in depth. So choice of reduction is whenever in the lateral view there is an angulation of more than 30 to 40 degrees with functional deficit. And it was one of the papers showed that 30 degree of angulation results in loss of 22% of the finger range of motion. Buddy taping should, irrespective of this, was just to prevent malrotation, so that the orientation, the cascade of the hand is maintained. So this is a form of an ulnar gutter. You can see instruction plus posture. So whenever, since the metacarpal neck of the fifth metacarpal is very, it's not very strong bone, so you have to be careful about your pinning as well. So there was a bouquet technique described for this thing, which care should be taken to prevent the wrist extensor tendons by giving an incision and partially, the finger extensor tendon by giving incision and partially elevating them. So this is a diagram. So the wire is about 1 mm, and you have to bend it so that it enters at an acute angle from the proximal part of the bone. And this is just basically, most of us has seen the bouquet. So here, consider this as the metacarpal. This is the metacarpal neck, and this is the metacarpal shaft. So you put the wire. So this is the proximal area of the bone is holding it, and is just filling the distal area which is comminuted, so that the reduction can be kept in place. Now, some thing about the PIP joint fracture dislocation. It is always an unstable dorsal displacement of the middle phalanx, and it is caused by disruption of the attachment of the volar fibrocalcitoninous plate. If there is single fragment with greater than 50% of joint space involvement, so open reduction is a very good thing to do. If less than 50% active motion of PIP joint while maintaining finger's extension block is a very good thing to do. This Dr. Kamran also showed you in his presentation. So dynamic external splint reduction for this technique relies upon the coupling distraction and volarly directed forces around the joint in fracture dislocation of the PIP joints. Basically, you put 3 wires, and then these wires act as dynamic splints. And this procedure can be done in local anesthesia, and you can immediately allow motion as well. Interphalangeal joint dislocation, usually they are more dorsal, easily reduced, and the collaterals are usually intact. But if the ligaments are ruptured, particularly the radial collateral, so you need repair. So with persistent dorsal subluxation, the joint may be pinned in 20 degrees of flexion for about 2 to 3 weeks, not more than this. Very rarely, a dislocation may be obscured by swelling, and at this undiagnosed the joint cartilage, you have to see that you need open reduction. So you have to see the joint, the condition of the cartilage. So the distal phalangeal fractures, usually they are presented to us with crushed comminuted fractures and only require splinting. In some cases, you do a 22 gauge hypodermic needle supporting the bone so that the soft tissue can heal. And sometimes it can be fixed. I have no personal experience with compression screws for distal interphalangeal joint fractures, so prevent non-needles. This is next is showing that thing. So the topic is very detailed, but since the time limitation is there, so I just went very quickly through the major things. So in summary, the management of intra-articular fractures depends upon fracture location and pattern of injury. We have been discussing since morning that treatment should seek to allow for early motion to prevent long-term stiffness, pain, and arthritis. This is a very important point, that restoration of joint congruity and early range of motion usually supersedes anatomical alignment. So if you want to take a message home, this slide is the thing. And you have to respect, from Dr. Chima, Dr. Khalid, all were discussing about protect the soft tissue, protect the tendon gliding. And so whenever you are fixing it, you have to keep very careful to respect the soft tissue. Thank you very much.
Thank you, Rizwan. So just in the interest of time, I will request Dr. Hashmi to kindly share his screen. Dr. Hashmi will speak about the soft tissue coverage, particularly local flaps, I guess. Thank you, Dr. Hashmi, for joining us.
I'm going to talk about soft tissue coverage for the small defects of hand, which will exclude remote flaps like abdominal flap, groin flap, and especially the free flap. We know that hand actually it needs sensate coverage on a certain parts of the body, especially on the fingertip and on the volar surface. And coverage of soft tissue, it depends upon the geometry of defect, its size, and the shape of the defect. And we need to consider the local factors like exterior of vital structure, especially the bone, tendon, joints, and you see the creases of motion, they have to be covered with the system. Now, if you look at the defect, we commonly classify the. Now, we know that the ladder of reconstruction, it starts from the skin graft. It depends upon where it is located and which area we need to cover. And the skin graft, whether it's split thickness or the full thickness skin graft. Then comes the local flaps, which the local anatomy, we can actually cover various areas of fingers and the local flaps. We will exclude remote flaps and the free flaps. We know for the skin graft, we need a healthier vascular bed, specialized with a well-vascularized granulation tissue or when the epitenon and the tenon is intact. But it's not applicable in the flexion extension tendon and the joints and especially the neurovascular bundle. It should not be applied especially on the pressure area or those areas which are involved in our pursuing grip, especially on the pressure grip. Now, on the fingertip area, we will talk about various flaps which are required in the digits, palmar, now, we know that injury is the most common injury which most of hand surgeries encounter along with an orthopedic surgery, and it needs a soft, supple skin coverage. It should be sensate, and we need to try to preserve the length of the bone, especially, and it should constitute a rehab. Now, the approach, it will depend upon the age and dominance, digital history, medical condition, mechanism of injury, occupation, and anatomy of the finger defect. Now, what are the various options? We know that there is well-known phenomena less than 1 centimeter. You can actually cover it, especially in the children, with a daily dressing and let it granulate, let it epithelialize. Most of the time, you would be able to reconstitute that loss of its pulp skin over a period of 3 to 6. But sometimes full thickness skin graft and what you mentioned, hypothermic skin graft full thickness, which Dr. Tassim Chima actually described when I was his resident in the 90s, and we have been using it for many, many small cases where the defect size is almost a centimeter and so, and it actually reepithelializes. And the good thing is that there is a lot of reunion from the surrounding tissue also. And over the period of time, people they have shown that there is good sensation in those areas. My specific interest has been on the digits, and if you look at the digital artery, we know that in a finger there are 3 digits, proximal, middle, and the distal, and the digital arteries run on either side, and at each level of a digit, it gives the 3 branches. One is metaphyseal, then diaphyseal, and then distal metaphyseal artery. At each artery actually splits into Y or T-shaped manner, 2 branches. One is the deep, another, and those branches go dorsally as well as laterally, and they all also supply the volar skin as well as the branch to the. And I had a chance of doing a dissection on the digits when I was a fellow in Singapore under the microscope. And based on that, these are my slides from my own dissection. And you can see those small blood vessels So one has to become familiar with the branching pattern of digital arteries. And I will just go one slide back. And if you look at that, there are three actually arches they are formed deep to the flexor tendons. They are at each phalanx. We can see that in the distal metaphyseal area, they are deep to the flexor tendon, these arches. So there are platelet circulation between these digital blood vessels. So one has to become familiar with the intricate anatomy and the digital branching system. And coming to the various labs, historically, the people they have described the exoit lab where you give a skin incision, but the deep vessel, they are not disturbed, and only you keep those small vessels and do a dissection in the small actually tissue while leaving those small vessels attached to the skin flap can be transferred on the volar surface. This is ideally for the small defect. Similarly, on the either side, the cuttle flap, it is raised on the lateral and the medial side of the teeth digits, and one can cover the defect. Now, these are the actually various flap patterns people they have actually described to include a neurovascular structure and the nerve. Then people they call it a neurovascular island flap. But in a classical exoid flap, you can see here it's the V-Y shaped flap with keeping those small perforators coming to the skin intact. It can be moved distally to cover the skin defect. Similarly, pulp defect, it can be covered with a thinner flap where you should make an H-shaped incision, raise the flap totally in those teeth, and cover the defect on either side, and after 3 weeks you do a detachment. Then one can actually do a coverage of especially index finger of the dorsal thumb. You can actually cover that defect based on its circulation. If you're familiar with anatomy, that the circulation is coming from the volar digit on the dorsal side. Cross finger flap is resident, and we started with actually learning and doing these cross finger flaps. We know that it can cover the large defect on the volar side. Based on that anatomy, because the dorsal skin gets circulation from the dorsal artery, for adjoining finger, you can raise the flap and cover it, the large side of the volar side defects. And these are the actually, if you want to make it a sensate, we know that from the digital artery on either side at the level of proximal phalanx, the dorsal digital nerve actually arises. And if one can sacrifice this nerve and anastomose with the digital nerve to make this dorsal skin flap a sensate cross finger flap. Now, these are the couple of examples of a cross finger where a volar side of a pulp, it can be reconstructed with a dorsal skin of a adjoining finger with a cross finger flap. In a small child, you can see the functional outcome. Another case, you can see that the big defect, almost the whole volar finger, it has been covered with dorsal skin in a finger flap. But going back, you see this cross finger flap, it can be a cross finger flap. The dorsal defect, where you actually raise only the dermal portion, skin, and along with this thick skin, you raise it, but the flap is raised on the other side, and you can do a reverse cross finger flap for the dorsal skin defect also. Now, this flap is no more actually is my choice, but people they can raise actually on the both digital arteries and move it distally. The disadvantage in the finger is that if you attach it to the nail bed, it can give you a parrot beak nail deformity, and it can lead to a flexion conjecture of finger because we do not have any hyperextension in the distal interphalangeal joint. Similarly, we can actually reverse vascular pedicle flap, the dorsal aspect of the finger, and here you can see from the dorsal side, you can actually raise the flap and cover the fingertip, but it would be an insensate flap. Homodigital flap that you can raise it from the same finger based on the dorsolateral skin. That is the commonest flap, which are the fingertip injuries, especially when there is a lot of volar skin loss. And there are a couple of examples. There is extensive skin loss. You can see the dorsolateral skin flap, which will cover the whole finger. And these are the couple of examples. And you can take from the adjoining finger if you have a lot of defect on the same side. This defect is not available. This would be from the adjoining finger based on it. Only on the blood vessel, you may not take the digital nerve. But if you have to take the digital nerve, it would be the only dorsal cutaneous branch of that distal nerve which has to be teased away to make it a sensate. The example of a neurovascular island flap in a small child, and another example of venous flap for the thumb. We know that there is availability of flaps, list Mober flap. Robert, whom I actually did my fellowship in hand surgery from Singapore, he described the flap from the dorsolateral aspect of the thumb, which we call O flap, then the neurovascular flap from the ring finger or from the middle finger, it can be taken lateral flap, and the various other flaps, and the Fauché from the Frenchman who described dorsolateral skin of flex finger based on the dorsal lateral vessel and the nerve, you can transfer it. And Mober flap, most of you are familiar that the volar skin, it can be transferred to cover a defect of 1.5 to 2 centimeter defect, and this actually gives an excellent coverage on the volar side. And these are the couple of examples. You can make a volar transfer DY shape in CN to further cover that defect, and you will get an excellent result. O flap is a basic dorsolateral skin, which from the thumb side, dorsolateral artery base, you can actually cover based on the dorsal radial branch, and there is a small vessel on that you can cover the defect. O flap. Similarly, from another finger, if you take it literal, which describes the only disadvantage is that it will give a sensation of having a ring or the middle finger from which you have raised the flap. But the only thing which you can do is then you actually sacrifice digital nerve of that flap and anastomose with the ulnar digital nerve of thumb, so that you have an exact good cortical reconstruction, that conditions are not lost. These are the of those flaps which we do. Fauché flap, Dr. Cassin has a lot of experience in that. For the volar side and the volar radial aspect of that, you can actually cover those skin defect flaps from the volar side of its pulp. And this is an excellent flap to give it coverage. This is a flap which I did in a small child, Fauché flap. Then you can do for the volar side defect, dorsolateral, another example. I'm just moving to a place where my battery should go. Oh, just wait a second. The battery has gone down. Let me plug in that battery. So these are the few examples of a Fauché flaps. Now, the web space coverage is another area which can be done with the various techniques. You can do a local rotation flap from the dorsum of hand. You can also do a coverage from the various local flaps from metatarsal artery base. This is a local flap with the defect of the dorsum of at the level of empty joint, which was covered with a just local rotation flap, keeping the epicon intact so that you can apply a full thickness skin graft on the other side. So for web space, most of the time you can actually open up the web space with the multiple Z-plasties if you are familiar with the concept, and it opens the space and it increases the mobility of thumb so the thumb can reach to the finger. Now, coverage of defects of the fingers and the hands in the various areas which have been described, like the dorsal island digital flap, reverse dorsal metacarpal artery flap, iliac flap, radial forearm, ulnar artery flap, Beckett flap, and the posterior and posterior artery flap. So the dorsal metacarpal artery flap, as we know that from the dorsal metacarpal artery, its flaps, actually circulation is based on deep dorsal metacarpal artery, which runs deeply into the underneath the fascia of the interosseous muscle. Along with that, you can raise it and cover the defect on the dorsum of proximal phalanx even up to the PIT joint and beyond PIT joint. Now, dorsal digital island flap, we know that this is almost a sensate flap. From the dorsum of finger, from the same finger, it can be utilized for volar defect. Then the fillet flap, we know that once we know that the finger is not salvageable, removing its skeleton, you can actually use its skin to cover the dorsal, volar, or ulnar, the radial side skin defect. And you make a fillet and it will cover an excellent skin graft. Radial forearm flap, most of you are familiar with that, the radial artery during its course of from the elbow to the forearm to the wrist. It gives a lot of cutaneous perforator to the skin. People now they are using just a facial radial forearm flap instead of taking the skin, and it can reach to the dorsum of fan, to the volar speck, to the thumb, to the ulnar, thinner, and hypothinner area, and primarily you can actually cover the skin defect when there is a degloving injury with exposed bone, tendon. After debridement, you can cover that skin defect with a radial or Chinese flap. Posterior and atrocious artery flap, I have a lot of actually experience, and most of actually speakers, especially Dr. Tasneem, Dr. Khalid, and other people, they have been doing it. And the numbers, they are actually now in hundreds. And we know that it has become a workhorse for the reconstruction of soft tissue flap to the dorsal of hand, for the web space, for the thumb, and especially for the thinner eminence. And in basic anatomy, most of it will be familiar. And there is hardly any chance of failure. Less than there is a 2% incidence when this posterior and atrocious artery will not communicate with the anterior and atrocious artery. And skin can reach to the empty joint of the finger, to the web space. So this is just an example, a lady who had actually post-bone contracture contraction of web space. We did actually flaps on the both sides, and his thumb became actually functional. Another example with a contracted web space, you can see coverage of web space with the posterior and atrocious artery flap. This is the actually end result in that case. Thank you. For the sake of time, I have actually gone quickly through those flaps.
Thank you, Dr. Hashmi, for summarizing very important part of hand injuries in a very short time. So I will take this opportunity to thank Pakistan Orthopedic Association, Pakistan Society for Surgery of Hand, and organizing committee of the Orthocon, and as well as the galaxy of the speakers here. So I enjoyed all the talks, learned a lot, particularly the chat we had in the start of session. That reminds me after the morning round at Bahawalpur Hospital with Professor Chima. So thank you very much, sir. And the question and answer session, we requested all the participants write in the chat box, but anybody can raise his hand to ask any question if there is any. In the meantime, I will request Professor Chima to give his comment, overall comment on the webinar.
Great. आप अरुण साहब बहुत नेकी का काम कर रहे हैं. एक तो आप ये इल्म फैला रहे हैं, दूसरा लोगों की बोरियत भी दूर कर रहे हैं कोरोना सीजन में. और मुझे तो ये जो इन फिजिकल प्रेजेंस से भी ज़्यादा इफेक्टिव तरीका लगा है, और खर्च भी कम है, आने जाने की कॉस्ट से भी बच जाता है, एंड equally effective as far as transfer of knowledge is concerned. तो बड़ा ही अच्छा काम है, जारी रखें इसको, एंड आई एंजॉयड ऑल द टॉक्स. एक सवाल है रिजवान साहब से. रिजवान साहब सुन रहे हैं? कि आपने वो कॉम्प्लेक्स डिसलोकेशन ऑफ एमपी जॉइंट ऑफ द फिंगर का जिक्र किया, कैपलान का. बाकी स्पीकर भी कमेंट कर सकते हैं. कभी कैपलान लीजन देखा है आप लोगों ने? वो इररिड्यूसिबल डिसलोकेशन तो होती है, लेकिन कैपलान लीजन द वे इट इज डिस्क्राइब इन द बुक, वो कभी देखा है? क्योंकि वो कैपलान ने जो डिस्क्राइब किया ना, एक तो मसला ये होता है कि एक बड़ा आदमी, बड़ा नाम किसी चीज को डिस्क्राइब कर दे तो चाहे गलत भी हो, देन दैट लिंगर्स ऑन इन द लिटरेचर फॉर लॉन्ग टाइम. जैसे गैलन, जिसको उर्दू में जाली न्यूज़ कहते हैं, उसने कह दिया कि वो जो हार्ट है वो फ्लो गोज फ्रॉम राइट साइड टू द लेफ्ट साइड, अंदर पोर्स होते हैं. 1000 साल तक किसी ने उसको क्वेश्चन ही ना किया, जब तक कि वो हार्वे ने ये ना कहा कि ये तो सर्कुलेशन, पल्मोनरी सर्कुलेशन के थ्रू हो के आता है. अब आप गौर करें, नेटेटरी लिगामेंट तो डिस्टल है, उसका तो डिसलोकेशन या उसके मेटाकार्पल हेड से ही डिस्टल है, और सुपरफिशियल ट्रांसवर्स जो लिगामेंट है, दैट्स इनसिग्निफिकेंट लिगामेंट एंड मच मोर प्रॉक्सिमल. ये दोनों स्ट्रक्चर तो उसका इरिड्यूसिबिलिटी का हिस्सा ही नहीं हो सकते, या अगर हों भी तो इनसिग्निफिकेंट हिस्सा है। इसको आप जाके दोबारा एनाटमी की किताब खोल के गौर करके देखें तो कैप्लन के ने जो डिस्क्राइब किया था बेस्ड ऑन वन केस रिपोर्ट, उसका आर्टिकल निकाल के देखें, सिर्फ एक केस रिपोर्ट है। और दैट जो फैलेसी है दैट लिंगर्स ऑन इन द लिटरेचर, जो मेरे ख्याल में जो असल काज है नहीं, वोलर प्लेट तो वल्स होती है लेकिन वो डीप मेटाकार्पल लिगामेंट के साथ जुड़ी रहती है, और डीप मेटाकार्पल जो लिगामेंट है वो बड़ा स्ट्रांग लिगामेंट होता है, वो पार्शियली रप्चर होता है, तो दैट मेक्स इट इरिड्यूसिबल। इस पे जरा कमेंट चाहूंगा मैं सारे आजमी साहब को।
जी सर, मेरा ख्याल है आपने बिल्कुल सही डिस्क्राइब किया। मैं पहले भी एक दफ़ा आपसे डिस्कशन हुई थी, तो बेसिकली मुझे भी अपने इस कैरियर में मैंने 3 किए, और आपको पता है इसमें मोस्टली आपको वोलर डॉर्सल अप्रोच करनी पड़ती है, लेकिन अल्हम्दुलिल्लाह वो डॉर्सल अप्रोच से ही मैं कर पाया। और ये वोलर प्लेट की इंटरपोजिशन जो है वो सबसे अहम है, जो कि वोलर प्लेट इंटरपोज हुई होती है, जिस तरह मैं अक्सर कहता हूँ कि बटन होले नहीं हुई, तो जब तक कि उसको आप नहीं हटाते ये डिसलोकेशन रिड्यूस नहीं। मुझे याद है कि मैंने आपके साथ एक किया था जिसमें मुझे ये याद पड़ता है कि आपने वोलर और डॉर्सल दोनों अप्रोच की थी, इंडेक्स फिंगर की एंटी जॉइंट डिसलोकेशन की और ओल्ड डिसलोकेशन।
ये हमने हैंड सर्जरी में पब्लिश भी किया हुआ है, एक आर्टिकल है मेरा, वो हैंड फेलो था अफीफी उसके साथ।
जी जी।
और वो मेरे ख्याल किसी वक्त ये अब 2006 में हुआ, 2006 या 7 में। तो उसको हमने क्वेश्चन किया भी, ये कैप्लन तो ऐसे ही है, वो बच्चों के इट वाज अ बिग नेम, इसको लोग क्वेश्चन नहीं करते, लेकिन इस तरह होता नहीं है एक्चुअली।
लेकिन उसको कोई कोट नहीं करता। तो हमारा वो यही है कि आर्टिकल मुझे याद है वो पब्लिश हुआ था 2007 में, तो एक्चुअली उसमें एनाटमी भी आपने डिस्क्राइब की थी, इसकी एक्सपेक्टिंग मैकेनिज्म क्या है। लेकिन वो यही है कि लोग जो इंटरनेट पे जब जाते हैं तो वो कैप्लन की तो बड़ा नाम है और बुक्स भी सारी की सारी उसको रेफरेंस देती है। तो मेरा ख्याल है इसे एक दफा रिविजिट करके
रिजवान साहब कहाँ गए हैं, वो चौंके पढ़ के आए हैं रिसेंटली, तो जरा
उसका मेरा ख्याल है उसने टेक्स्ट किया है मुझे, उसका कोई इंटरनेट का मसला हुआ है, तो
सही।
लेकिन मैं सर मेरी सजेशन ये है कि अब हम अगला वेबिनार जो करें वो केस बेस्ड डिस्कशन हो, एक एक केस लेके आए सब, एंड देन वी हैव पैनल एंड वी कैन डिस्कस दिस।
वो ज्यादा इंटरेस्टिंग होगा वैसे।
हाँ जी, मैं इंशाल्लाह
केस लेके आते हैं।
जी जी,
वो आके पूछ लेते हैं कि कैसे डील करेंगे, फिर जैसे मैंने डील किया वो मैं दिखा दूंगा।
maybe we can have 2 to 3 cases and we can have a like good discussion starting from the assessment to
ज़्यादा इंटरेस्टिंग भी होगी और क्लिनिकली रेलेवेंट होगी
इंशाल्लाह सर। I will organize। रिजवान साहब,
गुड आइडिया।
जी अस्सलाम वालेकुम सर, सॉरी मैं कनेक्ट नहीं हो पाया था सर। आप कैप्लन लीजन का पूछ रहे हैं?
कैप्लन लीजन का पूछा मैंने, कभी देखा है
नहीं सर, इसके हाँ मैंने भी इसके बारे में जब रिसेंटली पढ़ा ना, तो वो मतलब इसमें द लिटरेचर इज नॉट श्योर अबाउट इट एज वेल, सो वो मैं क्योंकि हैंड
लिटरेचर में चैलेंज भी किया है और उसका अल्टरनेटिव भी बताया कि रियल लीजन क्या होता है। जर्नल ऑफ हैंड सर्जरी में
जी मैं हैंड क्लिनिक्स को फॉलो कर रहा था, तो उसमें अभी भी रिसेंटली भी इसके बारे में थोड़ा सा, मगर यू आर राइट के मतलब nobody is discarding Kaplan but nobody is supporting Kaplan as well, the literature जो मुझे समझ आया।
आप सोचें तो you will immediately discard it, क्योंकि natatory ligament तो distal है वो।
जी मैं समझ गया आपकी बात। यस यू आर मतलब
superficial ligament जो है transverse superficial, वो whether it's a flimsy ligament और much proximal, और वो दोनों तो काज हो नहीं सकते, तो इसके अलावा कोई काज होगा। और हमारे ख्याल में वो जो पार्शियल रप्चर है डीप ट्रांसवर्स मेटाकार्पल लिगामेंट का, और वोलर प्लेट उसके साथ जुड़ी रहती है पार्शियली, so that makes it irreducible.
Okay, sir. I again thank you very much. The most enjoyable part was the chat we had at the start of session, actually in this period of isolation, lockdown, and social distancing. So we will meet inshallah soon again. Thank you all the participants for staying with us. I hope you all enjoyed and learned something. We'll see you again. साथ अगला पोस्टर जरा share कर दें next webinar का.
Sure, sir, मैं
So
करता हूँ.
that is about the MRI of the shoulder. That an arthropod should know something about the MRI of the shoulder. I think that is tomorrow. We have our expert radiologist with us, and I hope all of you will join and will learn something about the MRI of the shoulder. So thank you very much. Kindly register for this webinar and see you again soon, inshallah, and Khuda Hafiz.